சரி சரி சரி.
Hello, hello, check, hello. Hello, hello, hello. Hello, hello, check now. Sound. Hello. Hello, hello. Hello, hello. Hello, 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 hello. Sound. Hello, check 1, 2, 2. Hello, check sound. Hello. Hello, check. Hello, check. Hello. Sound. 1, 2. Hello.
Lovely audience. Good morning, भोपाल. आप सबका स्वागत है इस सुबह की नई लहर में. चरणों के साथ उभरेंगे नए सफर के पहलू में. मिलके हम साथ बुनेंगे नए सपनों के तार. सफर ये कॉन्फ्रेंस का होगा यादगार. A very warm welcome to all of you. It's a great honor for me to be your host today. For today's event, myself Kshitija Gaikwad, Senior Radiation Therapist at Manipal Hospital, Pune, and my co-host Mr. Ajay Reddy from Dr. KLES Prabhakar Koro Hospital, Belgaum, and Ms. Donna Suzanne from Kalyani Radiotherapy will join us later. We are very thrilled to have the opportunity to guide you through this exciting conference. Our esteemed colleagues, delegates and respected speakers, it's an immense honor and privilege to stand before you today and welcome you all to Artticon 2024. An event that brings some of the brightest minds in radiotherapy from both national and international platforms. We, the radiation therapists, are the compassionate profession who bring ray of hope and healing to patients every day. Dear colleagues, your dedication and commitment to patients will bring well-being and make a profound impact on the lives of those you serve. We are really grateful for your role you play in the journey of recovery for the patients. On behalf of Jawaharlal Nehru Cancer Institute and Research Center, I extend a warm welcome to each one of you to this highly anticipated conference here at Ahmed Greens, Bhopal. This is a momentous occasion as we gather to share knowledge, exchange innovation ideas, and collectively push the boundaries for cancer treatment. Bhopal, a city known for its rich heritage, serves as the perfect backdrop for this event, symbolizing both tradition and progress. Guys, listen to this. भोपाल की मिट्टी में है एक नई रोशनी का एहसास. यहाँ हर एक कदम है इल्म और ज्ञान की प्यास. इस शहर की शान में हमने ये महफिल सजाई है, जिसमें विचारों की एक चमक सी छाई है. It's a pleasure that we have come together in this beautiful setting to discuss the future of radiation therapies, a field rapidly evolving through technological advancements and a shared commitment to patient care. Ladies and gentlemen, let's give a loud applause and join me welcoming Mr. Naveen Chandra Dubey for the Organizing Secretary of Artticon 2024 to the stage. This event would have not been possible without his dedication and vision. Mr. Dubey, the face of Artticon, will invite you to the stage to share a few words with us.
थैंक यू शिल्या। स्वागत है भोपाल में खूबसूरत झील की नगरी। गुड मॉर्निंग ऑल ऑफ माय डियर कलीग्स, फैकल्टी, मेडिकल फिजिसिस्ट, all my respected doctors from all over India. It is with immense pride and excitement that I welcome you all at Artticon 2024. A conference that brings together the brightest mind in the field of radiotherapy from every corner of our nation. This gathering represents not only a meeting of expertise but a commitment of ongoing fight against cancer and the promise of greater health outcomes for all over India. In today's fast-paced world, advancement in medicine and technology are evolving at incredible rate, and radiotherapy stands at the forefront of evolution. As practitioners, researchers, and pioneers in this field, each of you play a critical role in shaping the future of cancer care in India. From groundbreaking innovation in precision radiotherapy to emerging leading AI-driven treatment planning, your work is saving lives and offering hope to millions. The theme of Artticon 2024 is 4 line to 4 dimension in radiotherapy, and it could not be more fitting. Today, more than ever, we recognize that the fight against cancer is not fought in isolation but through the concerted effort of healthcare professionals working across disciplines. We are here to exchange knowledge, explore cutting-edge treatments, and address the unique challenges faced by Indian radiotherapy professionals in both urban and rural areas. On behalf of the organizing secretary, organizing committee, and our gracious host at Jawaharlal Nehru Cancer Hospital, I extend a warm welcome to each of you. Let us work together to save the future of cancer care in India and beyond. Once again, welcome to Artticon 2024. Let us use this time to learn, grow, and inspire each other as we work toward our shared missions, defeating cancer, one patient at a time. Thank you so much.
आपने लिंक शेयर कर दीजिए, लिंक शेयर कर दी, लिंक शेयर कर दी
सर। आपको भी दे दूं क्या?
आपका
नंबर बताइए।
95734। हमें उम्मीद है, विश्वास भी है
9573
शाम को
700
सुषमा एहसास
890
हमारे साथ होगा।
शुभ नाम क्या है?
इसका भी बात हो रही है। बहुत सारा धन्यवाद गुरिंदर सर, अजीत सर, हमारे प्रेसिडेंट, कांग्रेस चेयरमैन वाइस सर, संजय गंजर साहब, हमारे पंच तक। तो शुरुआत करते हैं श्री गणेश जी का नाम लेके, श्री गणेशाय करके आज के सेशन का। वंस अगेन वेलकम ऑल ऑफ यू हिल की नगरी भोपाल में। स्वागत, वंदन, अभिनंदन। थैंक यू मच।
Thank you, Naveen sir, for addressing the gathering. Now let's move on to the first scientific session of the day. But before starting, I would like to remind our presenters to ensure the time for the scheduled discussions and questions that are so valuable to our delegate. May gently request the speakers to finish the talk in given time limit of 8 minutes and 2 minutes given for the questions. So, ladies and gentlemen, I hope you are ready for the highly insightful and engaging series of discussions. It's now time to begin session. To lead this session, sorry, before that, we will be doing a Ganesh Vandana. seated. So, ladies and gentlemen, I hope you are ready for a highly insightful and engaging series of discussions. It's now time to begin the session 1. To lead this session, we have an extended panel of chairpersons. Now I would like to request Mr. Manoj Pillai, the senior most RTT working for more than 31 years in Mahavir Cancer Hospital, Patna, presented several papers at national and international level. Currently the president of ISRT Bihar chapter, a recipient of numerous awards and allocates with a wealth and of experience and an outstanding records in radiotherapy. We welcome you, sir. Next moving to Mrs. Madhuri Champute, senior most radiation therapist working for more than 24 years, currently working in Mahatma Gandhi Institute of Medical Sciences, Wardha. Next moving to the other chairperson, Ms. Arun Reddy, senior most radiation therapist with 19 years experience and presently designated as a treasurer of Association of Radiotherapy Technologists of India, working at Clear Medi Monarch Cancer Hospital, Nanded, Maharashtra. We welcome you, sir. And the other chairperson, Mr. P.C. Jaiswal, senior most radiation therapist working for more than 19 years of experience, working in Max Hospital, Delhi. We welcome you, sir. Now I kindly request our chairpersons to take forward with the scientific sessions. The scientific sessions.
Transformation of radiotherapy.
अभी आप पहले तो देख सकते
इस तरह नाम टेबल लगाए थे
A very good morning, respected chairperson, seniors and my dear friends. I am Sajal Singh Kunde, a student of postgraduate diploma in radiotherapy and radiation medicine, Institute of Medical Sciences, Banaras Hindu University. So I am going to present my topic, transformation of radiotherapy mobilizing thromboplastic mass into favorite character of pediatric patients. So purpose is that transformation of immobilizing mask into popular character mask to increase the comfortability, acceptance and confidence during treatment of pediatric cancer patients. So there are various challenges of pediatric patients which is faced in radiotherapy, and these are side effects, developmental impact, organ damage, hormonal changes, fertility issue, anesthesia, anxiety, fear and stress. And these are negative psychological impact. It may induce treatment compliance, patient throughput and treatment outcome. So as a student, this is the beyond my scope. So I wanted to do something for this negative impact. Why we choose this idea of mask painting? Because as commonly we use psychological fear on children, which is negative impact. Similarly, may induce positive psychological impact also. And we know patient will be alone during the treatment, so they feel anxiety, fear and uncomfortability. And most of the children idealize or connected with superhero character. So by using this thermoplastic mask, they feel safe, confident, comfortable with their superheroes. And these ideas taken from the Sunday Cancer Center of Malaysia. So coming to the method, when patient come for RT, we normally ask, do you wish to have individualized painted mask? If no, then we exclude it. If yes, we further ask, do you have any favorite character? If yes, then who is your favorite character? If no, then we provide list to choose from the list of characters. After that, we change the thermoplastic cast into favorite character. And here are the some favorite character lists for boys and girls. So coming to the material method, mask preparation. Here we simply immobilize thermoplastic mask according to reason. After that we go in for painting, and the materials which is used in painting, these are acrylic paint, paint spray, poster color, powder pens and brushes. We have to plan. In my college study, at least 10 patients, but I could manage only 5 patients, and the age group between 3 to 10 years, where 3 are male and 2 are female, and the sides are brain and head and neck. So here in this picture we can see the thermoplastic mask which is converted into their favorite characters. And in which there is no item were used which is induced to plant radiation absorption, and scattering were not disturbed. And before the actual treatment, dummy done of fixing the immobilization with the patient approximately 2 minutes to check the comfortability of patient. So here we can see the treatment setup of patient. As resulting, most of the patient shows favorable reply. This is only the subjective assessment. We increase in happiness and comfortability with out of 5, and decrease in fearfulness about the mask, which is 5 out of 5. And the retaining the mask with them as personalized memorabilia, which is 2 out of 5. So conclusion of my study is that transforming the immobilizing cast to the pediatric patient's favorite character mask, it increases the comfortability, acceptance and confidence. Thank you so much.
Thank you very much. Any questions on the floor? Okay, thank you. Next is an invited talk. Dr. Challapalli Srivastava is professor of Manipal Hospital. He is a chairman of Karnataka chapter AMB, secretary AMBA in 2013 and 2015. organizing secretary of Beyond to 2012 organizing MP meetings and he having a scientific publication of 25 plus paper awards 6. He is a coordinator of PhD and members, examiner and so on. He met the hand to Chellapalli Srivastava. I invited him. The role of Artticon is holistic patient care.
Thank you for your nice introduction. And thanks to the Artticon committee for asking me to be a part. So, yes, my topic is of role of research technology in holistic patient care and beyond technology. The objective of as you can see in this picture, the objective of Artticon is from 4 lines to 4 dimensions. So we have moved a long way from almost 2 years to recently the total machine where we are seeing the target moving and we are capturing the target and we are giving the weight variation to the motion and motion. So we have moved a long way to the last diagram of the 3D case. We want to emphasize the essential role of digital technologies, not just as an operation of the advanced technology, but vital contribution to the overall being in a holistic care application. So I just want to add quick across and set up a detailed description. As you can see here, the regulatory data is being started somewhere in 1990s. So as you can see here, 1896 in Chicago, the UK has been in the best transformer and they have been well treated with the regulation. But as you can see, the squamous cell carcinoma is known has been well treated in 1959. The first year of the cancer has been reported. We all know very well about what is the basic objective of the radiotherapy, which is to give the maximum radiation dose and reduce the dose to the surrounding structures. So we want to ensure the activity is related to the target site where we want to do the research radiation of the target, lesser radiation on those structures. So we want to capture it and where the exactly the target is there and we want to focus it and we want to do a very lesser number of radiation of the surrounding structures. So we want to curate the patient with an acceptable light and we do things to provide the radiation target and later the machine is to live out the radiation in all directions and then there is a probability and then very well last week we did and we have go on to the new action items with high radiation and everything all parts of the body and conventional radiation. So there is a lot of technical advancement that has been taking place from almost 1950 to almost nowadays. So as you can see here, the slide, the biological target volume that is almost using with the help of the positron emission tomography. We will able to see the target and we will able to minimize the normal tissue loss to the surrounding structure. So it's a way that almost you can see for the last 3 decades so much advanced has been taking place now. Nowadays now we are almost in the I think we can see the conformity of the radiation dose to the specific target. So we can able to see the normal structures, the earlier period and those to the normal structures is almost basically data is very high. And as you can see in the current period, we were able to point out the dose related to the biological target structures. So dose versus relationship we can able to see And this is being a prescribed dose and total control probability, you can see the graph. And it's for a prescription dose of, say, for example, say 50 grams, we are able to see the model says. And whereas if you go to the NDCP model, that is a slightly enhance the dose to the target, and there is a, we are getting almost a little here, but there is a large enhancement of the normal tissue dose. So, in modern radiotherapy techniques, what we used to do is that tumor control probability, the graph, and as well as normal tissue control probability graph. We wanted to just widen as maximum as possible, so that we could achieve the objective of the radiotherapy. So that is how we were able to try to achieve. This is given a hypothetical model, and we are trying to see that. So advances in the radiotherapy. Basically, because of an homogeneous dose to the surrounding tumor tissue as well as a lower dose to the tissue, this both will give the high therapeutic ratio, that is the best therapeutic ratio that we are able to see. So, the treatment of the cancer, it was a very much a multidisciplinary approach, and we could able to see this, the achievement can be done with the help of radiation oncologists as well as medical physicists, and not only that, the therapy technologists. And these people are placed in a very vital, important role in this particular achievement. So therefore, ultimately, there are the three people who will be taking care of the patient, and we want to have a multidisciplinary group. We need to have a better collaboration among all these people, and contribute to the treatment planning, identifying issues very much early in case of patients having some reactions or responses, and it will give you about the valuable insights the patient comfort as well as patient challenges and etc. So the basic steps in the Artticon process, I will not able to emphasize it more, just as a take-up condition stage. Positioning immobilization is a very important component where the first the step process. Then later, as you can see, we will be able to take care of the patient control as well as we will take care of the image acquisition, and followed by the anatomy definitions, appropriate anatomy to be delineated by the radiation oncologist, and the physicist has to have appropriate view placement and characteristics, and one has to have those characteristics followed by plan evaluation and followed by the treatment execution. So this is how the entire process, and finally we have to have either offline view or online view. We have very sophisticated technology that we associate with it. So all these exercises will come in a specific and umbrella. So this is the entire steps of the radiotherapy process. So I mean to say that with the chain and this entire process, and chain as well as the link is very important when this dealing of the radiotherapy process. Specifically, radiation technologists and physicists and technologists are very important component, and the technologists team is actually taking care of the very high-end technology. As you can see here, actually the outside temperature is I think almost below minus, but actually the reading shows is 190, but something is wrong in there. So, though we are dealing about the technology, I will to say, we must be very cautious about what is happening there. Whether numbers are correct or not. Something like the human intervention is very important component. So, it's not like that what we see here, but the numbers are based on the is it correct number or right number, that we have to have checked. So, therefore, in Arctic process in DRS 490, critical request 490 this is the process from the imaging to the almost the first treatment. Every process there is a people are there to associate to take care of that as well as the quality assurance activity. So this is well documented in the literature to take care of this process. As you know, we are dealing about most of the centers are dealing with the high-end treatment with the help of linear accelerators, which are being capable of delivering high-end treatments like intensity modulated radiotherapy and management radiotherapy and so on and so forth. But actually, all these type of high-end treatments are related to say you require an appropriate image guidance is required. I mean to say the image guidance as an appropriate more focused decision is image-based therapy. That means the use of imaging for defining the target and the use of the image guided use of imaging to monitor as well as the molecular treatment. So there are fundamental definitions have been given in the different therapies. So high-end treatments wise, as you can see, the treatment treatment, and we want to capture the target in exact the right position when the target is at motion, and the volumetric art radiotherapy also we are doing nowadays, and with very high precision goes to the several structures like we have the example of the card. And of course, proton therapy, we have the precise that proton is replaced by the dose and beyond which the dose is almost nil. And of course, helical donor therapy. I would like to say the precision and accuracy are very, very important components in treatments. But I would like to say without which we can't see, we cannot, image variance is not there, we cannot be able to deliver research without treatments. Example, if you can see, this is in a picture where if that is a target there, we want to see the clinical goal. So if you cannot see the target, you cannot treat the target. And if you cannot treat the target, you cannot cure the target. I think I'd like to say here, you see it, you can hit it, you can hit it, you can cure it. So therefore, that's the importance of that in this space. So you have to have a see the target in appropriate location, and if we are giving a wrong delivery, we are going to almost missing the targets and the answer. So be careful when you are taking care of certain higher treatments, whether are you doing right job or right job. So that's it. So as I said, the process do happen. There is insufficient education. You should understand the technology properly, and lack of procedures and protocols in place, that is also important, and lack of supervision as well as quality assurance program, as well as a lack of training. You have a improper training that you really don't know what to do, what to do, take it about it, and what about it. Unusual situations like a safety culture which is not there, it is also a need to have any direction in the therapy process. So I mean, overall, I would like to say the excessive workload. As you can see here, the excessive workload is there in, old area also, and even excessive workload is also there in modern area also. So workload is also being matters a lot in bringing the quality. So therefore, quality assurance is very, very important. And the principles are there, quality assurance principles are quality assurance culture, we are encouraged in the department, adequate resources like for example, staff, equipment, training, as well as the time for proper functioning of the equipment, as well as clear written protocols are being required for the important of the quality assurance program. So errors should be disclosed locally, it should be neutral, and it should be means of the risk management. So we should encourage the errors. This is the errors which will happen and how it will take to the proper measures. So therefore, these are the things we need to take care and define accountabilities to a person and what are the roles and responsibilities that needs to be taken care. Regular checks of the Artticon has to be conducted, regular checks of the machine as well as associated gadgets, and we need to prioritize the patient safety with the help of the quality assurance program. So one has to have a safety culture, and which is being handled by the institution, and followed by the members are there in the roles and responsibilities, and need to be encouraged in the department. So I would like to say in quality assurance principles, the basic issues is the important thing is the education is very important, as well as the documentation. We have to have a proper documentation of the procedures. Not only that, but also the verification and followed by the communication. So these are the core important tasks that need to be done. So radiotherapy technologies are playing a very prominent role in leadership in taking the work. Such Artticon plays a very vital role in smooth execution, ensuring the treatments are very on time, schedules as well as managing efficiently, and record maintenance system into the patient-related mission as well as the quality assurance registers. Patient care counseling is very, very important. I think I have seen one of the paper in the Artticon conference, there is a counselors, and radiotherapy is also a good counselors. As one paper is also there is a poster, and I have to see about that. And I could able to say a couple of articles on the technologies as a SPEM also can be as a counselor. So patient experience reactions to anxiety, so understand fear and anger, so on. So in that way, technology space is very, very, very important in this picture. Proper communication with the patient is important. Lack of communication can lead to isolation as well as frustration. But I would like to say a successful radiotherapy always depends upon a good communication skills. So that has to be done from the specifically from the you are the persons that will benefit using the technology. So that really matters a lot. So that's what I would like to say. A new theory has been emerged out as a technologists are doing a good conservation. Because they know about the machine, they know about the process, and they know about what is the condition of the patient. So from there to here to almost adjust. So in that way, they are the people who will be able to take care of the patient counseling aspects. So during the counseling time, so they should not be any phone ourselves, and seeking education is important. Upon as well as gadgets, we should not wear and do. Atmosphere should be very cordial. And wall clock is necessary. How much time we are spending on the patient, that is also required. So, in the counseling skills, acceptance is very important. Unconditional acceptance is very important skill that should be followed. I would like to say, architects should be aware of the patient physical condition as well as disability as well as disability. So, don't get your person by religion or culture or gender, and don't be biased by stigma associated with the cancer. And we should be with the bias when the treatment of patients. So, the rapport we have to take care of. So, we have to show not only the sympathy but we have to show the empathy. All the patient centers are very good with the technology and goodness himself. I am so person. I am taking care of you the interactions and further more. So, that is where you are gently, you are introducing yourself to the patients. It really matters a lot. I don't force the patient to speak with this. So, let the patient speak on it. So, don't force the patient to speak with this. So there should be sometimes an emotional ventilation. Patient should be very more emotional. Let the adult patient to cry. And let the adult patient to do a regulation. So therefore patient will feel much better after that. So explanation to the patient, we level to this procedures that we do. I know that I going to say unnecessary anxiety, I will adopt this. So it is very much essential that one to explain about the most before the regular, what are the type of nurse they are using, how they are using this by say, harmful, and all those things are not going to explain here. As the duration of the therapy and the other side of this. Artticon must understand that the patient is not deliberately trying to be uncomfortable, but because of his illness and condition and psychological problems are being coming on the day after treatment. Maintaining confidence also, I did not able to express it. So there are some rules and do nots are available to visually impaired patient and mentally impaired patients. Patient education and support, and there are various documents are available in literature, so I can go through this. I have already given these slides to the just one can able to take this slide for the part of education. Contribute to the clinical research, I would like to say here, articles of patient development, clinical research. Some of them are very actively involved and they are encouraging, they are contributing also. So I would like to say nowadays articles are coming to the clinical research activities. So to summarize some of the slides, there are advertisements are there in the old advertisement as well as the new advertisements. But one thing I would like to say, don't be so fancy about what technology we have. And the old technology there, we are also moving ahead and about the destination, of course, nowadays there are real times also. But when there's are many accidents will happen in the old technology, it's not matter of not being fatal incidents, it's not of an injury. Whereas if you are dealing with higher technology, when you are going to a village and an accident, you need a lot of damage. So I'd like to say in summary, and success of radiotherapy does not depend upon you have linear accelerators, you have a proton, you have a beam, and so on so forth, analysis. So I would like to say you have good communication skills for doctors, speaking in universal language, and consistency in volume units, and so on so forth. This is beyond technology we need to take care. It's not either like, oh, what technology, or best by implementing the technology to the patient, taking care of the psychological conditions. So, in outside, we are dealing with lot of targets and the patient, where the target is going to be ignored, but adaptive therapies, IGRTs, all these things are relevant to the problems in the coming to the picture. So, everything should be made as simple as possible, but it's not simple as possible. So, teamwork and precision and quality assurance will be taken care of the patient. So, that's what I would like to say. Successful radiotherapy depends upon good communication, patient, and great patient.
Thank you very much, Dr. That's a wonderful talk. hand over mic to my co-chairperson, Mr. Arun Reddy, to call the next speaker.
Next call upon Mr. Sharan Kumar, who will present the total body radiation, PBI, within the extended techniques, patient setup, mobilization, making simple of the complex, a single institution experience of as per the guideline. Mr. Sharan Kumar.
Good morning, dear friends. I would like to extend my sincere thanks for giving this opportunity at Artticon 2024. Today we will discuss on the total body radiation with an extended technique, particularly focusing to the patient setup optimization. My goal is to make it simple for the complex while enhancing the treatment techniques by reducing the risk and patient discomfort during the treatment. A structure of presentation goes through the introduction, the concept of TBI, indications of TBI techniques and dosimetry. Through the preparations, CT simulation preparations, and finally through a pediatric case discussion and conclusion. Through the introduction, in combination with chemotherapy, TBI is most commonly used as part of conditioning regime for a hematopoietic stem cell transplant. TBI provides a uniform dose of radiation to the entire body, penetrating areas such as central nervous system and testes, where traditional chemotherapy is ineffective. Radiation therapy allows tailoring of the radiation therapy dose with the usage of shield and boost treatment fields, thus making the purpose of TBI as a threefold, like eliminating residual cancer cells, to provide space for the stem cell engraftment, to prevent rejection of the donor cells. Through the concept of TBI, as we know, the TBI is most commonly used as a part of conditional regime. Target volume is the whole body, including the skin and the target cells. Organ with high risk of recurrence and primary extent are given additional dosage. Organ at risk are lung, kidney, liver, spleen, heart and eyes. Sparing of organ at risk is to maintain the organ function in a large sufficient volume. Going through the indications of TBI, leukemias in adult and childhood like AML, ALL, CML and MDS. Optional indications such as solid tumors in childhood like neuroblastomas, Ewing sarcomas and plasmacytomas, which are in clinical tests are morbus Hodgkin's disease and non-Hodgkin's lymphomas. Through the TBI techniques and dosimetry, a single bit field covering the whole body of the patient at an extended SSD technique remains as the simplest and the easiest one currently. It can easily, as it can easily overcome the dosimetric and uncertainties through addressing the intersections of adjacent field, minimizing the concern of reduced dose absorption by the circulatory system. As researchers are exploring the delivery of TBA treatment at conventional SSD using advanced techniques like IMRT and VMAT, but limited clinical experience has been reported so far. The literatures have documented various methods of effectively irradiating the entire body with ongoing advancements in physical dosimetry and irradiation techniques. Through the dosimetry, the TBA technique aimed to deliver a consistent dose of entire body, but variation in shape and density have led to a plus or minus 10% dose uniformity requirement. Local dose adjustment may be necessary to protect organs like the lung and increase cell killing in the areas like bone marrow. These decisions are influenced by patient's medical condition. Some of the examples of TBA techniques used are vertical beam, a parallel opposed vertical beam, a wide angle vertical beam, longitudinally moving vertical beams, and patient transition while the beam is on, as a swiping while vertical beam. All these needs a special kind of treatment units. As in the horizontal beam, patient is supine, and patient horizontal beam with patient standing or sitting, horizontal beam with patient in lateral leg position. All these pictures, which indicates or which gives us an idea of how challenging was the traditional TBA setup. Our past experience have highlighted the significant time investment required for conventional TBA, often resulting in delay and increased patient burden. This made us to think about a drive towards simplification. Our efforts are made now focused on developing streamlined and more accurate TBA methods by simplifying the process. We aim to enhance the patient comfort, to reduce the treatment time, ultimately improves the overall accuracy and precision of the dose delivery, thereby transforming a traditional complex process into a more efficient and effective treatment modality. How do we implement it? Our challenge was to scan the entire patient length of 160 centimeter in a single scan range. But the actual scan range was covering only 120 centimeters. By using our SBRT indexable couch top, which is attached to the CT simulation couch, which was measured as a 6.5 feet long, which is 196 centimeter. We have extended the couch top around 40 to 50 centimeter cranially. That made us to achieve the maximum couch translation as sometimes 60 centimeter after extending a 40 centimeter. This made us to scan the entire patient in a single scan. Hello. Sorry. Actually, this was the turning point of our successful TBA program. As a part of the pre-treatment preparation, certain floor markings were done for the couch for its easier positioning, for the beam spoiler, and markings were done for the couch on the midlines and superior and inferior limits. This is the overall placement of the setup. accessories used where the patient was in supine position. Customized knee supports and head supports were made.
Kindly please.
Bolus
Time up.
material was used as a rise and 0.5 centimeter bolus was wrapped around the lower limb and 2 centimeter bolus was covering the lower limb. This is the overall setup of the patient. And access center was moved with the couch with motorized movement. Treatment was verified, the treatment beams were verified visually, and the bottom images were verified for the lung shield, for the abdomen, and for the lower limb. Beam spoilers were kept at 5 centimeters away from the body. Certain checkpoints were done with the rise back placement distance to isocenter, couch markings, block checkpoints, and floor markings, and beam spoiler distance, visual field confirmation, and MU delivery. Consequently, it was documented, and the patient was closely watched during the treatment for any this allowed her to view her favorite content through the radiation process, which enabled the therapist to get the maximum cooperation of the patient during the treatment. Here is a simple video showing that. And this snapshot provides a concise critique on different approaches, emphasizing how we have simplified this process. To conclude, the challenges associated with traditional TPA, specifically the complex setup process and the inherent uncertainty in the dose delivery, have prompted us a drive towards simplification. Past experience have highlighted the significant time investment required for conventional TPA, often resulting in delay and increased patient burden. Furthermore, the potential for variable in dose delivery introduction and element of risk and necessity meticulously monitoring. Recognizing these limitations, efforts are now focused on developing streamlined and more accurate TPA methods. By simplifying the process, we aim to enhance patient comfort, reduce treatment time, and ultimately improve the overall accuracy and precision of the dose delivery, thereby transforming a traditional complex process into a more efficient and effective treatment modality. Thank you.
Thank you, Mr. Sarma. I request you, presenters, please maintain your time. Presenter from Mr. G. Masu. Ready to practice patient surgical correction methods.
Good morning, everyone. I'd like to thank organizers for giving me this opportunity. My name is Bruce Manishimwe, and I'm an international student from Data Media Institute of Higher Education and Research. My today's topic is radiotherapy practice with great focus on patient setup and correction methods. Introduction and purpose of this presentation. Here we found that radiotherapy is key modality, where we found that over 50% of patients, of cancer patients, are receiving their treatment course. And patient positioning and memorization in radiotherapy is key factors in minimizing deviation during treatment session. And proper setup ensures accurate radiation delivery, reduces exposure to general issues, and enhances therapeutic outcomes. Our purpose is to evaluate and optimize patient setup and correction methods used in radiotherapy while improving accuracy and efficacy. Key objectives: here we assess current methods for patient setup in radiotherapy, and we try to evaluate existing practices and identify common errors and challenges in patient positioning. Also, we will have to address some errors and correction techniques. Finally, we explore advanced correction technique for precision. The way we conduct this research was we reviewed studies from 2010 to 2024 with much focus on innovation in patient setup and correction methods assessed in radiotherapy, and some data sourced from PubMed, Scopus, and Web of Science, including both qualitative and quantitative studies. But much focus was innovations in imaging technologies, visualization devices, and real-time correction methods in patients treated for head, neck, and breast and prostate cancer. So first, let's start with visualization techniques. Mostly in nowadays, in modern visualization, we are having vacuum cushions, plastic masks, bite blocks, and those visualizations are very critical in ensuring patient stability. And it is worth note that accurate visualization prevents patient movement and enhances repeatability across treatment session. And advanced immobilization, such as stereotactic frames used in stereotactic radiosurgery, SRS, and body radiotherapy, SBRT. These frames they help to ensure sub-millimeter precision in patient positioning, help us to prevent compromising treatment delivery. But we do have some challenges, and here we have few of them. The most challenges we found anatomical changes, mostly due to weight loss, tumor shrinkage, or swelling. These things can alter the patient body shape during treatment course, requiring replanning. Other challenges, it is mostly respiratory motion. Most of the time, this happens for tumors in the lungs, liver, abdomen, which we found these organs may move due to breathing and may complicate accurate targeting of the tumor. Other side is patient comfort, where we found prolonged mobilization in an uncomfortable position can lead to patient movement. I want to emphasize this, ensuring that continuous monitoring and corrective measures are critical to minimize these challenges and ensure effective treatment. Some common errors we found in patient setup. Here we found incorrect mobilization, failure to adequately secure patient leads to movement, causing off-target radiation. Example, inconsistent use of plastic mask in head and neck cancer due to weight loss. Also, we found other errors due to inaccurate positioning, where slight deviation can result in significant respiratory errors. Example, we can say misalignment in breast cancer patient during tendential field setup. Another errors it may come in during interfraction and intrafraction motion, where there is a movement between or during treatment session. Example, most of cases is prostate motion during treatment due to bladder and rectal filling. Also, set up deviation from reference images can bring some errors, where we may find differences between brand and actual positioning, which can occur, especially without daily image guidance. Example, most of the time we face with spinal misalignment in patient treated with for metastatic lesion. But research shows that setup errors can lead to up to 5% reduction in the tumor control probability and 50% increase in complication for surrounding health tissue. Reference is Botfeld 2014. We see some impact on treatment outcomes. Patient setup, we found that it has a great impact on treatment precision. When using advanced imaging techniques such as IGRT, CBCT, and ART, adaptive radiotherapy, significantly can improve targeted accuracy and minimize damage to health tissues. After all, physicist Howard Jones said, if you can see it, you can't hit it, and if you can't hit it, it means you can't cure it. So this means to see the tumor is the basis of IGRT, image-guided radiation therapy. On clinical impact, studies showed a 50% improvement in local control of tumor and better protection of organs at least when advanced imaging used accurately. Reference we found in Abundant MT ITERA 2004. Also, immobilization will have an impact on quality of life. Here is the way the patient experiences fewer side effects, such as radiation dermatitis and oral mucosis with better setup protocols. So, in context of technological advancement, both 3D imaging and IGRT, where we found cone beam CBCT and optical distance indicator offer precise verification and patient positioning before treatment. And also adaptive radiotherapy, adjust treatment plans in real time, accommodating changes in patient anatomy, example tumor shrinkage or weight loss. And this will significantly improve treatment outcomes. And here is the fact, studies report 50% improvement in tumor targeting when using adaptive radiotherapy. References is Bressio ITERA 2020. I want to conclude with a few takeaways, saying that technological advances in patient setup and correction method can and is significantly improving treatment precision. It is fact that incorporating these innovations and using them accurately can reduce setup errors and improve outcomes by enhancing tumor targeting and sparing health issues. Future directions for research should be widespread adoption of these techniques is very, and ongoing research should focus on further defining correction methods and ensuring accessibility across all treatment centers. So I want to thank you for attention, and if there is a question.
Thank you, gentlemen, for giving the presentation. Any question from audience? This lecture, remind of Mr. Ashok Reddy, is the General Secretary of ARTTI. He is the additional career spanning decades experience working as the leading therapist in Apollo Program Cancer Center. Had a 19-year experience of this field. Mr. Ashok Reddy.
Morning. I have two colleagues who study every day 2,000 lives with the radiation. So, warm hands. So we need to just thank yourself that you are touching the lives of the cancer patients and every day. And welcome to Gopal, and thanks to the organizing chairman and organizing committee for such a wonderful kind of high-five kind of. So as I'm becoming the general secretary, so this is my first time. I'm just talking about the administrative part, kind of like the career development and all. This was not my cup of coffee before, so I was completely in the clinicals, but now I just shifted it to the as a general secretary of ARTT. So I need to forcefully made me to talk about this. So and in this, which I got the data from the different sources throughout the world, which is some is official and some is unofficial, so I can't show the some citations where I got it from, but I can show the data what I got. Okay. Yeah. So empowering RTDs, unlocking the global career opportunities and advancing through research. So my presentation overview just shows the career upgradation and foreign opportunities for RTDs, and research and publications and leadership development. So why the career upgradation is crucial. Like just before my presentation, Jalapal Srinivas sir spoke about the career upgradations and how it's going to affect our career growth in a day-to-day lives, and at the same time, like how we are upgrading the technology-wise, but at the same time, our career-wise also, if we looking to build that aspect, obviously we have plenty of opportunities in the world, so where you can grow in a rapid course. Like basically when we are finishing our like diplomas or degrees, just get it stop at that particular point, and the most of almost only has a data like kind of very few percentage of people just they are going behind that and just going for the upgradation of their lives and even education wise and again profile wise. So the clinical practice and research, the leadership and education. So if you're shifting one by one, so to reach the service director professors, so we have that scopes in it. Of course, it may be not there every places in India, in every hospital, but few hospitals. Yesterday when I was talking to our board members of the ARPT, so they have the provision, like when they have the profile wise, if they get some kind of advancements in their career wise, so they have the scope of getting to the professor level of therapist in a few centers in India, especially in some government institutions, which is like recently released from the government of India memorandum. So in that, as especially mentioned, so when we have the kind of education qualifications, you can also reach up to the doctoral levels. So that's what like we got it. So when it comes to the global opportunity for RTD, so we have plenty of opportunities which is there as presently in the worldwide. In the worldwide, the radiotherapists our requirement is only fulfilled only by 50%, and remaining 50% of vacancies are distributed to the candidates who are capable of doing the higher education. Like even like in India, we have just started the National Commission for Allied Health Professions. So President Sir yesterday just spoke, so we are going to collaborate with that, so that it will be improvised in every way. So these are the different collaborations like we are planning the ARTTN. So through even like yesterday when I was talking to the founder chairman Srinivas sir, the request coming for the good conducting certificate to involve the abroad is significantly higher, more than if you compare with the past years and present years. It's significantly like more than 100% increase. So these are the different countries, they are providing jobs to Indian therapists where they have the proper qualifications. So the qualifications and all, everything they are mentioned in their websites. So the people who are interested, they can go through it. At the same time, before, so these are the these are the data, like over 30,000 radiographers are registered with HCPC. In that, almost the figure of the Indian therapists was nearly 12% of people were traveling from India, and after reaching there, they upgraded their profession. Like usually they will be in the band wise, like 5, band 6 and band 7, band 8. So people were getting to the research at the same time, that is upgrading their positions and day to day, and that was a growth story they are just showing over there. First, like how we have the ARPTI, so they have like SOR, the Society of Radiographers, which are for the therapeutic and as well as the imaging wise. So they have data about that, like the people in flow, which they are collaborating with HCPC as well as NHS as well as this radiographer. So everything they used to do that. But because this is like funding society, where the NHS can't do direct funding to the public funds to for the conferences and all. So they are just doing this SOR groups. So as per Canadian Association also, they have more than 22 MRTs working in the medical imaging radiotherapy across the country. 22,000, just imagine. So America, like they have approximately 350,000 registrants are there. So in that, of course, included not only the RTPs, at the same time tech imaging technology as well, but that percentage was almost equally same. So as per the ARB data, we have just only 8,000 radiotherapy technologists who are registered as the Aurora. So obviously without EORA you can't work anywhere in the like Indian hospitals. That's the mandate thing to work as a radiotherapist in organizations. So the Indian Arctic contribution to the world is like significantly high. So I just wanted to show that the radiotherapist workforce in UK census on 2023 last year, like the NHS England therapeutic radiographers, like and the band wise. So establishment the vacant as a present and the vacancy rate. So it's very high as compared with the past 2 years to present before 20 and after 20. So this is international recruitment during the previous year and the plan for the coming year under NHS. So the data shows like almost more than like 7 to 8%. It's number of like the hospitals which they are going to come up in the UK and the peripherals of the UK. So the requirement is just significantly high, and at the same time the international recruitment also just they are portraying in a very higher manner, because like in UK they have very less institutions where they are providing the courses. Because at the same time, I think like for the Indian scenario, the salaries wise, if I talk about that, where the candidate with the 5 years experience, what the salaries they are getting in India, and the same experience guy in UK, like I'm talking about Indian therapist who is working in the UK, and the same experience of 5 years, the salary structures and all obviously significantly high. So that's the reason, but at the same time they have some capping where they can the growth maybe it stops in some kind of band itself. But in India it's not like that. You can go up to the maximum peak for level. So in the code registration also almost you can see the requirement of radiotherapists, the social workers and the radiographers was 3,000, and the way the radiation therapists is only 497, where they are lacking with 60% of therapists. So their workforce is only the 40%. Only because of that reason they are just requesting the world to come into their profession. Previously Ireland never used to encourage anyone. So that's the reason just they are getting lax. So they are just pushing, the government is pushing the local people to go to abroad and get study about the radiotherapy and get into the country. So they are providing the kind of funding for the people. Like that happens usually in the UAE countries. So they'll abroad like US, UK to get the study and just come and work over there. The same way Kuru also, like just even for the Kuru registration, Sresa told me like since last 1 year we did more than some nearly some 200, nearly 200 registrations they have done through the Artticon. So when it comes to global distribution of radiotherapy missions and 21-23 is a IAEA reports. So where India is, and the figure shows for the per million people, per million people. So where we have 1.4 number of hospitals. So we have only less than 1% is represented in India. So where like UAE countries and where it comes to the Western countries, so they have only more than like 5 missions per million people. So where the entire world itself lagging about their infrastructure for the radiotherapy. So when it comes to the